Okay, so good afternoon, everybody, once again. Thank you, everybody, for joining. I see the numbers are still slowly going up, but we're just past past, so I think we can kick off as more people join. To start off, I'd like to hand over to our new regional advisor here in ESA region, and that's Chris. So Chris, over to you to kick off. Thank you.
Thank you, Mara. And yes, I'm delighted to have joined ISARO earlier this month from Bangkok still. I'm really pleased to be introducing this very important webinar today. And I'd like to thank you all for joining this afternoon. And a warm welcome to all the colleagues from across the Eastern and Southern Africa region, our colleagues who are our neighbors who may be joining from West and Central Africa, and colleagues from the Middle East, North Africa, and a warm welcome also to our colleagues who are joining very early in the morning in New York, Louise, Shika, and others, and also some of our experts today, Hassan, Victoria. We're also from the GNC, and we were hoping for colleagues who also might be joining. If you'd like to introduce yourselves on the chat and say where you are, feel free to do so. So we've organized this webinar today because we thought the discussion around surveys and data collection is really important. The assessment of COVID's impact on nutrition status and practices and also nutrition services is very much on the agenda. We know that some countries have started to or planning to collect household level data, including perhaps anthropometry. Some countries are also switching to some mobile data collection using phones or online tools for surveys and also routine data. And of course, some countries have been planning or are planning to conduct nutrition surveys and maybe had plans for national surveys like DHS and MIX sometime this year. So there are lots of questions I'm sure you have around all these different types of data collection streams. What can we do? What can we not do? How can we protect the enumerators and the people we are wanting to survey? So we wanted to start this discussion today by hearing some examples from countries who are doing different things. And then of course to hear from the global level on what guidance there is around data collection in this unique context of COVID. So to quickly go through the agenda, I'm not seeing agenda on the screen. Mara,
Sorry.
are you able to share?
Yes, sorry, it keeps sticking, but I'm sharing now.
Great. So we're going to start by hearing from Burundi and Zimbabwe on their different survey plans. So a national SMART survey in Burundi and Zimbabwe's experience with vulnerability assessment. And then we're going to hear experiences about those alternative methods that I mentioned to in-person data collection. And Mozambique will share an example of their process of incorporating nutrition questions into WFP's mobile phone vulnerability assessment, or the MVAM. We also know that in many countries, MUAC screening activities have been affected, and we'll hear from Comoros how they are setting up a digital system to collect screening data from mother MUACs, which is really interesting. And then we'll hear from Eritrea on how they have ensured continuation of routine survey reporting, since the pandemic started. So throughout the presentations, we encourage you to post any questions that you have in the chat box, and please highlight who you are addressing the question to. And if possible, I'd ask the presenters to answer in the chat box when they can. But we will have some time at the end of all the presentations, so not after each one, but right at the end for Q&A. We're very lucky to have many data and survey experts on the call today. So please do use the opportunity to ask your questions. So without further ado, let's get started. And thank you very much.
That's great. Thank you very much, Chris. And as you've said, without further ado, I will hand over to Elizabeth in Burundi. Apologies, Elizabeth, my turning my page keeps sticking, but I'll hand over to you while I sort out the presentation.
Hi, Mara. Hi, Christiane. And hi, everyone. Hi, colleagues there.
Hi, Elizabeth.
So,
can you see now?
Yeah, I can see the agenda. Yeah, now it is okay. I have a slide now. Okay, so just want to present where we are in the preparation of our National Nutrition Smart Survey in Burundi. So the context of the country regarding COVID is that to date, to July 22, we have 328 cases that have been confirmed and 1 death so far. Okay, in this slide, you will see that I just want to give an idea of nutrition, globally nutrition indicator at national level. So as you will see, we have a high rate of exclusively breastfeeding, which is from last year nutrition survey. It's at 77%. We have high rate of stunting above 50%, and this rate has been stagnant over the last 20 years, and it is the highest rate in the region and even globally. This situation contrasts with a low wasting rate, which is at 5% at national level. We have some provinces which are at 7%, but it is all are less than 10. And we have poor feeding practices. The minimum acceptable diet is at 6% as national figure. I've just put here 4 maps, and you will see the map from nutrition smart indicator from DHS in 2010, and after that the second DHS in 2016-17, and the first nutrition smart survey that had been conducted in 2018, and now last year 2019 figures. As you will see, we are monitoring progress. I know that standing did not move within 1 year, but we decide at country level to have a nutrition survey annually, so that we can be monitoring progress in terms of feeding practices and also nutrition indicator. So since 2018, the country UNICEF support with the government and also with other partners as World Food Program, we support the annual nutrition smart survey, and every 2 years we decide to conduct a joint nutrition and food security assessment. The first one have been done last year in 2019. So now we are in the preparation of the annual nutrition smart survey. Next. Next slide, please.
Sorry, Elizabeth, coming. I don't know what I'm doing wrong, guys. Sorry. Okay, this is your slide, right?
Yeah. So why we are conducting survey in the country? So as I just said, we decided to organize annual survey plan to keep nutrition at as high priority for the government. In the country here, we have some kind of denial of nutrition figures by the government. So UNICEF start pushing since 2018 so that if we collect regularly data by government partners, we think that they will accept figure finally. So that is why we have planned it like that in our monitoring and evaluation plan. We used to, the two last survey was done during lean season, but this year the government decided to postpone it. So we are going to organize the data collection in August, something around, somewhere around August, I think, the data collection, so that they want to have a figure different from lean season. So the 2020 survey will be organized in August and September. We have also some kind of pressure from the government because of COVID. Partners maybe would be all partners were agreed to postpone maybe to next year, but the government want to conduct this service. So for us, it is good. We need to support them and to ensure that protective measures are in place. And for this survey, all anthropometric data will be collected. We will collect high weight and other indicator on IYCF will be also collected. We'll also collect data on vitamin A coverage and vitamin A coverage and child morbidity. What measures are in place in terms of protection from COVID? With the government, we plan within the survey activity and survey budget to respect global guidelines. And also, we are going to train trainers, national trainers via Zoom. That is one point, but we will ensure that we have all the survey team, they have all related PPE and hygiene kits before, during training and also during data collection. So we can learn from other countries that has already started data collection, what they are doing, so that we can maybe arrange our strategies. What we think that we can also discuss and get from the government is that all survey team, supervisor as surveyor can be asked to have the COVID test. Right now, since 1 week, the government starts mass testing for everyone, and it is free of charge. So we think that the survey team can get the test, and that will be one point of protection in addition to equipment that we are going to provide. So that is where we are in our preparation. We plan the training of trainers for next week, and we will be glad to hear from other countries and to learn from other countries in the regions. Over.
Thank you very much, Elizabeth. So just please bear with me, everybody. I'm just going to hand over the sharing to Louise. There we go. And while she's getting it up, we're going to go straight on to the next presentation, which will be Zimbabwe. As Chris said at the beginning, if you have any questions, please write them in the chat box. There's some time for questions and answers at the end as well, and we'll address as many of them as we can then. But for now, Kudzai, over to you. Thank you.
Thank you very much, Mara, and hello to everybody. I'm Kudzai Mkudoka, and I'll be presenting for our experiences in the ZimVac, which we are actually in the process of winding up. The actual data collection is in the process of winding up. So just going to share some of our experiences. Next slide, please. Our context really is that as a country, and looking at the ZimVac process, we could not rely on our previous data from 2019 because a lot of the assumptions that we made in 2019 do not hold true. We are a country which is rapidly evolving in terms of our macroeconomic situation, which is very much linked to our political stability as well. We also had a very poor season last year, and our inflation is increasing. Our total consumption poverty line in April was at about 7,400 Zimbabwe dollars, which was 703% higher than the previous year. So we had a very our context is things are changing so rapidly within the country, and COVID then came in on a dimension where we were already struggling as a country in terms of food security, in terms of nutrition security, particularly linked to the macroeconomic environment. And linked also to that is when we had our new government come in, we used to have a document which was called the Zim Asset, which was the economic blueprint for the country. It was the country's planning document. And in this document, nutrition and food security was very clearly spelled out. And in fact, it was pillar number 1. However, with the new government and with a very strong focus on trying to get the economy right, trying to rebuild and re-strengthen relationships, nutrition somehow fell out of the Transitional Stability Plan, which was the economic blueprint from 2017 up to 2020. So very little investment then started going towards nutrition. And so as a country, we are now in the process of updating those economic blueprints. We will be coming up with a national development strategy. And we will also, this year, we have commenced our work on our national food and nutrition security strategy. And so it was key for us, and it was key for the government to have a credible baseline that was not extracting or extrapolating from previous data. And also linked to that was also the limited options or alternative options for doing sort of remote surveys. And this is why, as a country, we opted to go for a field-based household survey. Next slide, please. So the considerations that we had to make, obviously, the process needed to be highly consultative amongst the UN and also very much with government. Ministry of Health was the one that was leading on the infection and prevention control protocol. Government really took a very strong lead in this and in wanting the ZimVac survey to go ahead. And we used ICT platforms for most of our meetings, and also we used a decentralized approach when it came to the actual field work, so we could limit the movement of people, particularly from central level, and minimize exposure. And it's important to note that at the time of planning our survey, our ZimVac, we had less than 250 cases, and we had very little community transmission. And in fact, our COVID cases were largely in the main cities of Harare and Bulawayo, and mainly again related to returnees. So at the time of the survey, we took the risk of exposure to be limited. We now currently have a spike in community transmissions. We are currently, as of yesterday, we were at 2,034. But at the time that we started the survey, we were at a very low risk. Next slide, please. So in terms of the methodology, we used, not much was changed in terms of our methodology. We used mixed cross-sectional and panel design. By panel design, we were identifying households that have participated in the survey in 2019 so that we could try to do some trend analysis. And all of this is based on our Food and Nutrition Security Conceptual Framework, which has been adapted by the Food and Nutrition Council. And the sample size, initially when we had wanted to include nutrition, our sample size would have been about 420 households per district. But when nutrition anthropometry fell off as an indicator, we used food security indicators, and this gave us about 200 households to be interviewed in a district. The house in a selective village, you select a household which had been interviewed in the previous year, just to do a bit of triangulation and trend analysis. Next slide, please. We are very fortunate in terms of our enumerators that we use. So our enumerators were drawn from a database of experienced cadres who are operating within that particular district. So no one had to travel from outside in terms of the enumerators. And these enumerators were drawn from health, agriculture, social services, and from our statistical agency, but also local government. And a lot of the work on the ground is actually coordinated by the district administrator's office, which is under local government. So also a lot of sensitization and community mobilization was done by the local government. And in terms of also sending out the messages that when enumerators come, the protocols that households needed to use, social distancing, wearing masks, and so on. So we also had local government doing that sensitization and community mobilization for us, as well as, of course, extension staff within Ministry of Health as well, particularly around Mother MUAC, and I will get into that. And our enumerator training was centrally coordinated and facilitated virtually through online Zoom platform. There were a few districts that had internet connectivity challenges, and these were then trained by the national and provincial supervisors who have been dispatched using the face-to-face approach, and we'll show you a couple of pictures of that, whilst of course observing IPC protocols. And so movement of national and provincial supervisors was limited, and data was collected using GIS-enabled tablets, and there were daily data checks which were conducted by the national data and analysis team, who would give feedback to the provincial teams, to the national supervisors on any issues that were arising from the quality of the data or any questions that were being missed out. Next slide, please. So these are just pictures of the actual training of enumerators, showing observation of IPC, and just observations of social distancing, wearing masks, and so on. Next slides, please. In terms of the data that we collected, our ZIMVAC is quite comprehensive in terms of covering vulnerability indicators. So education, health, WASH, nutrition. For nutrition, when we were originally planning, we had wanted to do full anthropometry. One of our major limitations around anthropometry was the issue of height boards. We mainly have the wooden height boards and not the heighttometers. And there was a very strong collective feeling that they would be cumbersome to disinfect every single time, and we could possibly run into the risk of exposing mothers and babies, and also the enumerators unnecessarily. So after much debate back and forth, we opted to at least go for MUAC measurement only as a screening measurement. And it was important for us to include MUAC because our routine data sources show that there are a couple of hotspots across the country where there are increasing rates of GAM. And so that was of concern for us. and we needed to be able to at the very least, to screen. Next plan, please. So in terms of MUAC measurements, we initially had thought that we would use village health workers or the Ministry of Health personnel. But given that we have an ongoing program around MUAC, we took the opportunity to distribute MUAC tapes and to train or to talk the mothers through the MUAC, taking MUAC. So these photos are showing a mother taking MUAC of her own baby. So what we were also trying to do away with, again, the risk of exposing any child or any mother to COVID, and especially through our enumerators. So mothers handled their own children. Under the instruction of the enumerators, we did have anthropometrists. As I mentioned, we had people from Ministry of Health. Next slide, please. So these are just pictures of some of the MUAC measurements going on with the caregivers. Next slide, please. So our IPC measures during data collection, we had daily temperature check for all survey team members, including drivers. Masks were worn in vehicles and at the household at all times. Logistics teams and supervisors remained outside the homestead. They were not allowed into the homestead. Sanitization of hands before and after each interview. Physical distance of at least 1 meter during interviews. Disinfection of all gadgets and equipment before going to the next household. MUAC tapes were left with the mothers and the caregivers, and all supplies were availed before visiting a household. And it's important to note that these instructions were, of course, were part of the training and were enforced throughout the survey. And we are pretty satisfied that the protocol was adhered to during the whole assessment. Next slide, please. So this is just a couple of pictures showing our enumerators interacting with the households. Next slide, please. And observation of physical distancing. Next slide, please. So in terms of our lessons learned, of course, consultation and technical consensus are critical. It's not always easy getting to that technical consensus, and some trade-offs need to be made. As we mentioned, that we had wanted to have the full anthropometry, weight for height, but we also needed to take into account the limitations. We also needed to take into account the risks. So we're in the confines of the ZIMVAC committee and getting that, which was good to get that technical consensus and to agree on a way forward. Having an enumerator database of enumerators who have already participated in similar surveys reduces the amount of training that you actually need to do. So you're not starting with new enumerators. So in terms of a trade-off, in terms of the number of days that were needed to have been increased due to the fact that we're taking a little bit longer to household in terms of preparing before getting into a household, and also sanitizing or disinfecting as you leave a household. Having people who are already experienced really helped. District trainings, as I mentioned, also did take longer due to connectivity issues, people platforms, and also due to the time that needed to be spent pardon me. If you can hear me, I'll go on.
Yes, because sorry, colleagues, we have some colleagues who are not on mute. If you're not speaking, please mute your mics.
Yeah, let me continue. I hope you
Yeah,
can hear me. Okay. One of the other issues that took a little bit longer in terms of the district trainings was the time spent in translation into vernacular. Our tools are often printed in English, and then in terms of our role play and making sure that we understand and are standardizing the questions in the same way, we translate into vernacular. And on online platforms, that did take a little bit longer in terms of getting right down to the right interpretation of the question, but not significantly longer that it came at an additional cost. There was no major additional cost to the survey because of this. We also utilized and will be utilizing our multi-sectoral food and nutrition security committees to now take on for routine monitoring. Having done the assessment, we know that we will not be able to go to the field as often, but we have district members who are already there, who are already stationed within these districts and are operating there. And we are strengthening our support to them, our technical support to them, and even financial support for them to conduct routine monitoring of the food and nutrition security situation as it evolves. And mothers and caregivers are really important in terms of participating in nutrition screening, and it's a key programmatic area for consideration going forward. Our extension systems providing routine data need to be strengthened. I think there's a major assumption that we have extension systems and therefore we can get this data there and we can get that data there, when in actual fact, when we tried originally to pull data and find out where the gaps were so that we could just concentrate on the gaps, there were actually major gaps in our routine extension systems. So in terms of trying to avoid field level surveys or household level interaction, we need to strengthen those extension systems that are already working within the communities to provide more reliable, timely, and accurate information. Community involvement is key, and the empowerment in the whole process, because ultimately, as you saw, we ended up having to use the communities themselves to do some mobilization, using the mothers to take MUAC. Next slide, please. So our future considerations as a country and for the ZIMVAC is really to establish a comprehensive food and nutrition security information system, including capacity building for the routine monitoring that I've just mentioned. Also, one thing that we are currently lacking is a nutrition framework for selection of indicators and method for remote data analysis. Which indicators do we take? Which can we actually analyze for remotely? Which are we going to have to focus on? That could really strengthen our data collection and our considerations for future surveys. We also need to support convergence and collaboration of information systems within the UN, and also strengthen our community monitoring mechanisms. So briefly, these are our experiences. It's been an interesting assessment, especially in terms of the planning. The actual implementation was so much simpler than the planning. The planning is when there was a lot of headbutting, a lot of back and forth, but by the time we got to actually implementing and doing the survey, no major incidences have been recorded, no major issues, no budgetary issues were reported. The data quality from the checks that have been done was quite in order. We will be beginning data analysis and hopefully getting into report writing in the next week or 2 weeks. And I'll be able to probably speak a whole lot more to data quality going forward. We also appreciate very much that MUAC is a trade-off, and especially Mother MUAC is a trade-off. It is not the gold standard. And there are some challenges associated with it. And I'll be happy to report back once we've looked at all our data in terms of the quality of our MUAC measurements. I thank you. Over.
That's great. Kudzai, thank you very much for that very comprehensive presentation. I see there are some questions coming in the chat box for you and your team in Zimbabwe, and also for Elizabeth and your team in Burundi. So maybe you can be addressing some of them as we carry on. And now we're going to move on to hear some of the more alternative methods for data collection. And over to Thomas in Mozambique. Thank you.
Thank you, Mara. Hi, everyone. This is Tomás from UNICEF Mozambique country office. And going to very briefly take you through the experience that we are still having with the use of MUAC data collection. So basically, to flag that this is still work in progress, and I am basically going to take you through how was the process and what were the challenges that we faced in the process. A little bit of background. Surveys in Mozambique integrated, I would say, integrated food security nutrition surveys, which are led by Minister of Agriculture, and a very specific secretariat that monitors the food security nutrition situation throughout the country, and also Minister of Health under the Nutrition Department. And annually, we plan surveys to inform, to see whether there is any potential emergency related to nutrition and address accordingly. Next slide, please. So the question, why MVAM? And this question is can be answered in a very similar way than other countries. And the major reason was the COVID pandemic and the declaration of the state of emergency in Mozambique, which was effective as of 1st of April. And with that said, there was many activities that were put on hold, including, if you can hear me, I will proceed. I'm hearing some feedback of that.
Thomas.
So as I was saying, with the state of emergency declared and due to COVID, many activities, either health related and as well as from Minister of Agriculture, were put on hold, which included those surveys at district level that were planned for the lean season, including the cyclones Idai and Kenneth affected areas, as well as drought and conflict affected areas also. And with those activities on hold, the need for information was, and it's still there. So after that, knowing that information is still needed, WFP country office, through the VAM unit, which are quite well experienced in using MVAM, they shared a plan of doing vulnerability assessment through, in their target districts, and they shared that with within the vulnerability assessment technical working group, and jointly we explored the possibility of including nutrition into that platform, and it was at the first place, it was a little bit how would I say, the government was a bit reluctant in including in using MVAM for some reasons that I'm going to address in the next slide. But then after that, WFP made available, the nutrition unit made available about $10,000 to support the integration of nutrition, to make sure that the plan of always having nutrition integrated within the food security is met. So they made available around $100,000 to support that integration. And the list of indicators included was basically MDD, MMF, and childhood diseases like diarrhea, dysentery, fever and cough, and also some indicators on how seeking behavior within COVID-19 context. And there was also support from the regional office, both WFP and UNICEF, where they came with a list of potential indicators that could be used in that platform, and it was accepted basically, as you can see the list here. Next slide, please. We had many challenges, I have to say, and just to give you an overview, the discussion around using MVAM started in April, if I'm not mistaken, and until now, the interviews per se have not yet started, and they are planned to start next week. So there was a lot of back and forward discussions, and Heza will I'm going to briefly explain here. With regard to sample size, the design was beforehand done to respond to food security related question, and as you may know, food security it's quite flexible in their design, and it was designed to be valid at provincial level, so about 800 households per province, and we have around 11 provinces. So nutrition indicators were integrated following the same design, and we still don't know for sure how many observation we will get for each indicators, but after we have data, we will see. It's also an opportunity to learn whether this works for nutrition for real or not. Another challenge was the the food security team wanted to use MVAM data to do IPC, acute food insecurity analysis. And according to the IPC AFI protocols, data coming from MVAM should have at least 6% coverage in terms of household having an operating mobile phone. So that raised a lot of discussions, because in Mozambique we were not sure what is that coverage, and we tried to look back in existing data, like the very recent census that was done in 2017 to have information, but it was quite challenging, and I think it was dropped out to. They might not going to use that for IPC, because WFP wanted to. They're the ones who had the majority of funds to support the activity, and the time frame with the donor was running out, so they had to put pressure on that to make sure that they use their funds for the intended activity, and probably they might not going to use for their data for IPC, acute food insecurity, given this limitation and coverage of operating mobile phone. And we tried as a group, we tried to see how IPC Global Support Unit will be flexible enough to review the condition, especially in the context of COVID, and it was not possible to the best of my knowledge. And at a certain point, the discussions a month, because we had to we had some surveys that was done in November to December 2019, and we put that on hold to make sure that we use them with other surveys like we usually do. Other surveys that was going to be conducted at the beginning of 2020, and given COVID, they were canceled. So we used those surveys to run IPC analyses while they're still valid in terms of their validity. So the discussion was continued after that process, and it's happening now. The operationalization itself is happening now, and there was also another challenge right at the beginning from the government side. The secretariat SETSAN, we call it SETSAN, that leads food security and nutrition surveys and monitorings throughout the country. They didn't want to use MVAM because they fear that it could replace the use of traditional approaches. And then WFP was called to give a very detailed presentation explanation. What is MVAM? How, when can MVAM be used, which fitted in the context of COVID-19, as well as in areas where access is not possible. And within the technical work group, it was finally accepted to move forward with this approach. Next slide, please. So current stage, after all this conundrum, I would say, WFP finally, they hired a company called Geopol that is usually responsible for conducting the interviews using their platform in local language. And interviews, like I said before, are planned to start next week. So Geopol, basically they program the questionnaire into their platform, and they also run the tests of the questionnaire before they actually start with the interviews. And they run interviews, and they share the database with the let's say WFP in this case, who is the one, WFP and the government also, or who are the one leading this process for the next steps. So this is basically what this is where we are, and it was what I wanted to bring to everyone attention, what we are doing here in Mozambique with regards to using innovation to fill the gap in information. Thank you.
Thank you very much, Thomas, for that. That was very informative. And I see time is running away with us fast, so we'll move straight on to Ben in Comoros. And Ben, just asking you to be mindful of the time and stick to your 10 minutes if possible. Thanks, Ben. Over to you.
Okay, thank you, Mara. Good afternoon, everybody. Thank you to give us this opportunity to share with you the MUAC of Mothers Initiative that we are setting up here in Comoros in the context of COVID epidemic. Next slide. Mara. Hello. Okay. The context Comoros, the first case of COVID in Comoros was declared in the end of April. And now to date, we have around 300 cases of 7 deaths. As you know, in many countries, COVID epidemic affects the continuity of basic health and nutrition services. And the same things in our country, with the consequence of limiting the continuity of nutrition services, the community and health services, this including screening of malnutrition, vitamin A supplementation, deworming, and other services related to the nutrition, as like maternal nutrition. And sometimes, and mainly to the secondary effects of COVID, such as travel restriction and lockdown, we note that there is a risk of an increase in child wasting. In the face of the situation, we discussed with the Minister of Health to identify and to see how we can adapt our intervention to better manage the some programs that we continue to find and treat those children in need. Next slide. Our response regarding the epidemic context of COVID, when we discussed with the Minister of Health, we agreed that we are going to focus on the implementation of use MUAC by mothers at home for monitoring the nutrition status of their children. What's important is to note that in Comoros, in each health district, in the health post center, we have nutrition team, which they are involving in the SAM management. So our nutrition team at the health center will monitor the child study through the phone via the Kobo Toolbox tool. Our nutrition staff, they will call mothers who have been trained to carry out MUAC measurements on pre-agreed schedule to collect information from the mothers of their MUAC measurements. So when we will implement this initiative, we think that this implementation with this initiative will contribute more to strengthen the screening of SAM at the family level, but also contribute to find, refer, and treat the new cases, improve collection and data analysis, but also engage more with the community, associate the community, and implicate the community in the SAM management. Next slide. Next, how the application works. At the beginning, we created an application that it integrated the information we need to collect at home. Our nutrition team received telephones with the support of UNICEF, and in our planning, they will contact the mothers to collect the MUAC data of their children. And we think that 2 times per week, they will call the mother so they can collect the information we need. And not only on the MUAC measurement, but also they can check other things related to the nutrition, the health and the nutrition of the child. And also when they collect the data, our nutrition staff record the data on their telephone in an online application. Authority data can be recorded online and uploaded when internet is available. Once they will send the information to the central level at the ministry level through application we created. When the data are sent, nutrition at the national level, they will analyze in real times, and the application does the data analyze and produces the graph we need that we have already designed in the system. So the data we collect, as you can see, concern the age and the sex of child, the status of MUAC, the village of the child, the name of the mothers, etc. And here you have the link that allow access to the application. The server of this application is localized at the Ministry of Health, and the nutrition team at the national level is in charge to analyze the data that we collect from the application. Next step, next slide. The next, I think is the next, Mara. Okay, the next step, all the plan that are now in place for this, Global Talks has been set up and customized to our needs. The car telephone have been procured and the nutrition team received the telephone. Our next step now are to continue to train our SAM managers at the health facility to use the application through mobile phone. And we provide also the mobile phone, and we plan to train around 1,000 mothers on Mother MUAC by the end of December. But to date, we have trained 200 mothers on Mother MUAC. We'll continue to work with the district, health district, to reinforce our supervision. And also we are working with the Minister of Health to see how we can improve the nutrition information system. what is important here to note, our nutrition information system is integrated completely at the Ministry of Health through the Health Information System. So thank you very much for your attention. Au revoir. Merci, Mara. Thank you.
Merci, thank you, Ben, for that very succinct presentation. And moving straight on, we'll move on to Samson in Eritrea. Over to you, Samson. Hi, Samson. We can't hear you yet. I'm just...
Hey, thank you, Mara. Can you hear me?
Got you now. Over to you.
Yeah. Okay. Good afternoon, colleagues. And I would like also to warmly welcome Christine to our region. Before going into my presentation, a little bit of operational context of the country. When it comes to nutrition data collection, there are two critical elements or kind of bottlenecks. One, we don't have internet access throughout the country. So there is a very little or no room for innovation or high-tech data collection. At the same time, nutrition information is a bit politically sensitive. And the last time we survey for the country was 2010, and since then there is no nutrition survey, or there is no hope of doing it. So within this context, I would like to share with you how we managed continuity of adapted nutrition program in context of COVID, and also how we manage monitoring or data collection for it. Next slide, Mara. Yeah, so what we did was, in fact, we earlier adopted all of our programs to ensure continuity. Then monitoring or data collection was a bit a challenge on already existing challenge of no connectivity and no or absence of strong nutrition information system or mechanism. So we just agreed on key data elements to be fast-tracked in line to the program adaptation, and these key data elements are focusing on admission numbers or reach in terms of the various nutrition service we provide through telephone, mainly calls and SMS. This helped us to gauge on one hand the effectiveness of our program adaptation, and on the other hand, it also helped us to gauge the emerging needs due to the impact of COVID-19. The limitation to our approach is we couldn't have performance indicators and quality assurance monitoring data, which would be yet collected once things get back to normal, or at least when there is a possibility of movement in the country. Next slide. So using our fast tracking approach through SMS and phone calls, we have been able to manage some of the data elements, and we did also comparison with the same period to last year to see or to gauge how successful our program adaptation is. So mainly, as you can see in some of the indicators, we have reached almost similar or more number of beneficiaries compared to same period of last year, when you look especially the sum admission as well as the IYC counseling, while the MUAC screening is significantly lower than the same period last year. It has its own reason. I will explain when I discuss the community engagement part. It is due to limitation in availability of IP materials. And if you look at similarly the MAM case, more or less we have been able to reach the same number of children in January to June 2019 in 2020 compared to the 2019 similar period. and for the rest of the indicators, as you can see on the screen. Next slide, Mara. Yeah, so the key element for both the success of program adaptation as well as capacity to collect a few key indicators or data elements and compare program adaptation as well as emerging needs is the community engagement or the strong community-based network that we have here in area. The community-based tasks are conducted through the community health workers, which each one of them assigned for 50 households. There is clear guideline to the community-based platform to ensure infection prevention control measures in place. And the CHWs, those who have access, use simple face masks, disposable gloves for the once a month activity, which includes nutrition screening, the referral. So they do all the screening, referral, and the counseling tasks by themselves. We haven't yet planned or thought about Mother's MUAC, but that would be the way forward, providing the pandemic and the lockdown continues as it is now. They follow existing reporting system, at least from the lowest geographic unit, which is Kababi Medar, to the sub-zoba or district level. And there is no change in their reporting at community-based level or for community-based activities. The only change is from district to Zoba or subnational and to national. We're just only focusing on quickly tracking key data elements or indicators that would show us the number of service delivery to measure continuity of the service, as well as to see emerging needs as a result of COVID impact, which I tried to highlight in the previous slide. Thank you very much, and that's all me, and I hope I have used less time, Mara.
Very perfect. Thank you, Samson. Thanks for the great presentation. And now on to our last presentation, so handing over to Louise. Thanks, Louise.
Okay, thanks. Thanks, Mara. I hope you can all hear me. So I'm just going to give a quick update on the global guidance that we have currently in place. So the guidance that we have for nutrition surveillance and monitoring in the context of COVID was developed by the GTAM Nutrition Information Working Group. This is a working group that provides technical guidance on NIS for the GTAM, which sits under Global Nutrition Cluster and is supported by UNICEF and other partners. So through this working group, the main functions are to address NIS needs that come from countries, and obviously monitoring in the context of COVID is one that we have been concentrating on since earlier in the year. These are the different agencies that are represented in this group. And we have already produced our first brief, which gives broad recommendations on surveys, NIS activities, and monitoring in the context of COVID. And this came out in April 2020. There is an updated guidance which should be released shortly in the coming days. So the key messages which were highlighted in the first brief was one, to ensure that we continue to maintain physical distancing. Obviously, we do not want to get into a situation where we are spreading the virus. So this is extremely critical. And we use alternative ways for data collection. And this was in line with the global guidance on limiting the spread of COVID-19. We encourage countries to prioritize their data needs and leverage existing information systems in the country, and also, where possible, plan for alternative data collection methods. And it's interesting to see from the presentation from countries some of the adaptations that have been done to ensure that you're able to still collect data from for programming. The next was to ensure coordination of nutrition information activities. And this is both within the sector, within agencies, but then also with other sectors. And this will allow for a more coordinated approach to the data collection processes, but then also to leverage with other sectors and agencies on methods, other alternative methods that can be to address data gaps. We also encourage the maximum use of existing data. So really understanding what information do you have, what are the gaps, what information is missing for the key decisions that need to be made at a particular point. And then also looking at which data collection systems that you have and which ones are possible to be adapted for meeting these needs. And this is obviously in just not looking now in the short term, but also looking at long-term and medium-term needs. And then lastly, to avoid us even looking for information that already exists or collecting information that's already available through other sources, is that it is important to make information and reports very easily available, so for all stakeholders to enhance the process of decision making. So just to give you an overview of the updated guidance that will be coming out in the coming days, as I mentioned, is that we still are encouraging countries to maintain physical distancing and just be in line with preventing the guidelines on preventing the spread of COVID-19 and to use alternative ways for data collection. So this is still what we have in place. And what we're now encouraging countries is that if there is a need to collect data, then this need must really be weighed against the harms and the benefits. We are obviously, as of our work, the do no harm is extremely important. We would not want to be going out to collect information and putting communities at risk. So we are encouraging that for us to strongly weigh the harms and benefits of this particular information that is needed at this time. And we also are working with different partners to develop guidance on minimum criteria that should be needed to restart population-based surveys. This work is ongoing and is being led by the SMART team with CDC, also the MIX and DHS teams are also coming together to see what would be essential, both from ethical point of view, operational point of view, what is the minimum standards that we should consider before we restart population-based surveys. We also highlight the fact that, even if mobility restrictions have been lifted or governments and coordination mechanisms in country are saying that it's safe to proceed with primary data collection activities, we really are encouraging us to really review the key ethical issues in relation to undertaking any kind of evidence generation activities involving children during the COVID-19 emergency, but also post-emergency. And some of these considerations are, first and foremost, it's extremely important for us to weigh the harms and benefits of us undertaking the particular data collection activity that we want to do. And in country, this really needs to be a discussion where you weigh what is the benefit and what is the risk of going into communities to collect the information that you need. Of course, like I said, keeping in mind that we have the principle of doing no harm. And so we need to weigh what is the necessity of this data collection activity? Can we use different data collection mechanisms? Must this data be collected at this particular point in time? What decisions are going to be undertaken with this data, or what decisions are not possible to be made because of the existing data gaps? How does this impact our programming, for example? Are programs still continuing with the information that we have? And so these are really the things that we need to think through very carefully and establish a strong justification for us to be able to move forward. We have to consider the health and the safety of enumerators. We don't obviously want to spread this disease. So what kind of safety precautions are going to be put in place to protect everyone? And linked to this will be the resources that are required, because obviously we would then need to ensure that we're maintaining certain IPC measures, you know, the social distancing, the wearing the masks, etc. But this may also have an impact on how we, you know, hire enumerators. And from seeing some of the examples, you could see some are just hiring from that local area, those who are already in a certain database. How will you conduct these trainings to ensure that you're able to train the enumerators in a way that you're actually going to collect data that you can actually use, because we wouldn't want also to go through this process and come out with information that we cannot use. Will you have the sufficient materials that are in place? And this is obviously the basic things for now, like masks, gloves, sanitizers, soap, water. Is all this available for the enumerators to ensure that they are able to maintain the standards that are required? And, you know, are they sufficient? Is there a sufficient supply for these in country or in that particular area? And also weigh the risk of what we would need for actually implementing programs at health facilities, vis-a-vis using these resources for data collection activities. There's also the components of sensitization, how sensitization of communities be conducted. It's obvious, and this is done, we shouldn't make the assumption that, you know, that we can just collect information the way we have been doing in the past. These communities have also been sensitized on protecting themselves from the spread of the disease. So how will we be sensitizing them to the data collection processes to make sure that we're able to collect the information that we have? So this is some of the actions that we've elaborated in our brief. Also with that, some of these were from a UNICEF document on the ethical considerations for evidence generation during the COVID-19 pandemic. And that document is available online, and we can also share the link with countries. So in terms of key messages and the next steps in how to support us moving forward, the first is the Global Nutrition Cluster has developed the Nutrition Humanitarian Needs Analysis Guidance. This document is currently being piloted. It has been shared by the Global Nutrition Cluster, and so we would encourage countries to have a look at it, and also to try and use the guidance in conducting a situation analysis and also determining some of the needs. We would also welcome feedback on this document, as it's a pilot, and certainly if there's feedback to improve on it, we'll be happy to hear that from countries. The second is for us to critically map out and prioritize data gaps. We keep saying that, you know, we need to do a survey. What information do we want to collect from that survey? Is it anthropometry? Is it IYCF? Is it because we have a specific gap in that information? Is it is that gap affecting program decisions currently? Or is there information that we can use currently, but we anticipate that in the next 3 months or 6 months, we'll be in a situation where we will have a gap of data for a particular decision-making need. Then we need to identify that now, because that will allow us to be able to prioritize which information we need to collect and how we need to collect it. Because the next point is that we will need to leverage on what's existing. You can see, I think, from some of the presentations, it's easier to adapt from systems that you already have and collect information from them. So it is important for us to then really be clear on what it is that we want to collect and identify the gaps, so that if, for example, we're saying, okay, now we want to do family MUAC, or we want to or we have gaps in IYCF, then you're able to to leverage, for example, like I've seen on a mobile phone collection, or a Rapid Pro, or expanding maybe the DHIS and so on. So it's really important for us to be very clear on what information we want to collect and what decision that information is going to be used to make. And then we need to do this looking at our current needs, midterm needs, and longer term needs. This way we'll be able to make sure that we're able to adapt our existing systems, and also what the required resources will be for us to be able to collect this information. And lastly, of course, this is a situation that is very unique to all of us. And so for us to be able to move forward, we encourage us to document these different innovative ways that we're collecting information. We also appreciate the feedback that we get from countries, because again, this is useful for us as we're developing guidance and supporting countries to really think through the needs and be able to come up with guidance that is useful for all countries. So I'll stop there. I do have online Victoria from the Global Nutrition Cluster, who's been supporting on NIS. I also have Hassan from the SMART team, and Eva also as part of the SMART team, and also from CDC. Maybe as we go into questions, Mara, we can also just give them an opportunity to provide any additional inputs specific on the global work around this. Over.
Thank you very much, Louise. Yep, thank you very much for that very comprehensive update from the global level. Yeah, and indeed a big thank you to all our presenters today and all the rich experience that's been shared from all the countries. So as Louise said, before we go into any questions and answers, then Victoria or Hassan or Eva, would any of you like to add anything? Over to you, maybe Victoria to start off with.
Hi colleagues, nothing further to add at this point in time, and I look forward to being in touch with you individually regarding the guidance that was mentioned on the humanitarian needs analysis, and also any support that we could provide at the GNC level. Over.
Great, thanks Victoria. Hassan, anything from your side?
Hi everybody. Not at the moment. I'm happy to see the different countries and the adaptations that are being made. We're working hard to get the guidance out for resuming surveys.
That's great. Thank you, Hassan. Eva, anything from your side?
No, thanks for the great presentations. Available for comments and questions.
Thank you. Thanks, Eva. So then I know there's lots of questions that's already been put in the chat box, and Victoria has very kindly been tracking those for us. So we will make sure to get them all answered and send them out to you if we don't get around to answering all of them now. But before we go to the ones in the chat box, I just wanted to give anybody a chance who just wants to unmute themselves and take the chance of asking a question either to our countries who presented or to our colleagues from the global level. So, so colleagues, if you have any burning questions, please, you can raise your hand and then you can just unmute and ask your question. And if nobody has any additional questions from what is in the chat, then maybe we can go to some of the kind of more general questions in the chat. So I don't see any hands raised at the moment, but colleagues, if you do want to ask a question, please do just raise your hand. And Victoria, have we got a couple of the more cross-cutting questions to ask then at this point?
Yes, so from the CDC, there was a question regarding Mother MUAC, and this was a cross-cutting theme across a number of countries. So for all of the countries using, working using Mother MUAC, has any country asked the mothers to take measurements twice, such that within country measurement, there's a within a country measurement of precision that can be calculated?
Okay, thank you. Kudzai, do you think we could come to you on that one first, just to ask if that was considered when you were planning for the ZimVac, or if that was done during the ZimVac? Over to you, Kudzai, from your experience.
Thank you, Mara, and thank you for the question. No, it was not a deliberate effort on that to take it twice. It would only be taken twice if the enumerator observed any issues with the taking, or if the mother somehow failed to follow the instruction. But in terms of data quality and the checking for precision, no, we didn't do that. And maybe if I can just answer that, one of the reasons for maybe not having looked into that as well so strongly is the fact that we've also got the community health workers who are following up on the mothers as well. So the survey was not necessarily in isolation from routine community nutrition programming. Over.
That's great. Thank you, Kudzai. Maybe Ben in Comoros. Ben, do you have any thoughts around that? Asking mothers to take the MUAC measurement twice. Are you doing it, or have you considered it in Comoros? Over.
Hello.
Hi, Ben. Yes, you're unmuted now.
Hi, Mara.
Yep.
Can you repeat the question, please?
So just to ask if when you're doing your mother MUAC, have you considered asking the mothers to take the measurement twice, the MUAC measurement twice, just as a kind of quality control measure?
Yes, twice. Yes. We consider this.
Okay, and thank you, Ben.
We will do this. We consider this twice. Yes, measurement.
Thank you, Ben. Victoria, is there any other cross-cutting question that we can answer now?
Absolutely. The list is quite extensive, colleagues, so I think we'll definitely be doing a follow-up with the presenters and with you all. There was also a number of questions regarding testing of the survey team. And if colleagues, in terms of the primary data collection, can comment on whether the survey teams are tested daily, what are the plans set for testing, and generally, what are the procedures put in place to identify whether enumerators and or household surveys develop COVID-19-like symptoms during the weeks following the survey. So how was there the follow-up with certain enumerators and households, and also if any enumerators received testing before or after training and data collection. So general questions on the whole kind of testing package with regards to COVID-19, and how did countries consider this challenge? Over.
Okay, thank you, Victoria. So Kudzai, again, I see you've answered some of those in the chat, but do you want to just come in and respond to that one? And then Elizabeth, I see you have your hand up. I'll come to you after. Thank you.
Okay, thank. Hello, who is going to talk? Me?
Sorry,
go ahead, Elizabeth.
Can I go on?
Yes, go ahead, Elizabeth. Thank you.
Okay, just to answer Louis' question regarding testing, I don't think that it will be feasible to do a daily testing, because the test now is available in the capital city and the big cities. So what we think to do before selection or based on the COVID testing will be a criteria for selection of a survey team, mainly enumerators. But from this presentation, what come in my mind is that we can provide a team with thermoflash so that they can, with the supervisor is supervising two survey team, so they can have thermoflash so that they can be able to take a temperature every day for the survey team. That is what I have in mind. If not, the testing will be at the beginning of the training. That is my point. If you have any comment or orientation, you can give us. Over.
Thank you, Elizabeth. Could I over to you for any additions?
Yeah, okay, thank you, Mara, and thank you for the question. In terms of testing, no, basis. What we did do was were the temperature checks, and as I mentioned, that Ministry of Health was the one who took the lead on this. So in terms of the composition of the national team, we also had the COVID-19 task force members, and at provincial and district level, we had the environmental health department, which is the one that is doing, in fact, they're the ones leading the COVID-19, even at decentralized level, the COVID-19 response. From the household, we took the phone number of the respondent. Again, we also had to stress that it's, yes, we will, it's still anonymous, but we want to be able to follow you up 1 week and then 2 weeks later, just to find out also like a cross-check afterwards, just from national perspective as well. For some of us, like a number of UN agencies, and myself included, I was on the survey team, but I participated remotely. And we also didn't want to just rely on hearsay, but even be able to call up from the database that was created of phone numbers, randomly call up respondents and find out if they've experienced any symptoms, any flu-like or COVID symptoms after having been interviewed. So those are the checks and balances that we've tried to put in place. But really, it's important to note that we are working so strongly with the Ministry of Health and with the COVID-19 task force. In fact, we took opportunity during the survey to also be disseminating COVID messaging with the environmental health team. Over.
That's great. Thank you very much, Kudzai. And colleagues, I see we're coming to the end of our time. We just have another 2 minutes, so I don't want to keep everybody past the allotted time. I know we all have a lot of Zoom and Skype calls these days. So just again, a big thank you to everybody for all the participation. And again, a promise that we will get to all the questions in the chat box. And so presenters will be in touch with you, please, for some follow-up responses and get back to all of you. So thank you everybody very much for all your contributions. Have a great rest of the afternoon and evening. Thank you.
Thank you. Bye.
Thank you.
Thank you, Mara and the colleagues. Bye.
Thank you, Mara.
Thank you. Bye.
Thank you.
Thank you. Bye.